Hello, everyone. My name is Christina Saldana. I'm a PA in Winston-Salem, North Carolina, and the owner of Camel City Women's Wellness. My practice is a primary care practice that focuses on integrative women's health from menarche all the way through the menopausal transition. I deal with a lot of women who are struggling with hormonal imbalances, PCOS, PMDD, perimenopause, trying to figure out where they're at in their reproductive life and how to make themselves feel well, really from inside out. So I have two cases to share with you all today. Let's get into it. Number two is a little bit different. So let's get into her. So she's a 38-year-old female G3P2. She has young children, ages 3 and 5. Her past medical history is largely unremarkable, except for the fact that after her second delivery of her second child, she had an emergent hysterectomy due to postpartum hemorrhage. So she does not have a uterus, and that is actually her only surgery, is that she does not have a uterus, but she still has her ovaries in place, but the tubes, uterus, and cervix all removed. Her BMI is 28. She has a regular diet, which is focused on whole foods, and she cooks a lot at home. She is a therapist by training. For exercise, she uses her Peloton bike or tread and also lifts weights alongside of that 5 to 6 days per week. So she came to see me because she wanted to understand what her hormones were doing, similar to the first patient, given the fact that she had had a hysterectomy and she has no idea where she's at in her cycle. Again, she had a hysterectomy, but they did not remove her ovaries. Her ovaries are still in place. So conceivably, she is still having ovarian hormonal fluctuation. And she notices that a week or two every month, she is more irritable, has insomnia, has a shorter temper with her children. And then she also experiences some physical symptoms such as fatigue, bloating, low motivation, poor concentration during this time, which is starting to affect her professional work. And as I said, she is a therapist. So we completed some basic labs, metabolic panel, complete blood count, thyroid panel, folate, B12, D3, ferritin, cortisol. Everything is within optimal range. So there's nothing on paper blood work that looks to be out of the norm for this. So, oh, and I should say that this patient, I did do a PHQ-9 and a GAD-7 during a time frame where she was not experiencing these symptoms, and she did not screen positive for suspecting of a depressive or an anxiety disorder. So our plan was to start tracking with Mira, number one, to understand what her ovarian hormones are doing. For example, is she in menopause? I don't know. We don't know because we don't have a period or a bleeding pattern to kind of determine that. And then also to see if her symptoms that she's describing, do they correlate with ovarian hormone fluctuations or do they not? Like, is this a hormone, mental health situation such as PMDD, or is this just some other type of mental health situation such as cyclothymia or dysthymia or something like that? So this was her chart. And if you can kind of flash back to that previous patient, not what the previous patient looked like, right? Like, so she had a pretty characteristic, what I would suspect to be for a just typical, quote unquote, normal reproductive hormone picture for a premenopausal woman. So we can see here that in gray, her E3G levels are rising slowly that are leading up to that LH spike. And then she's having some fall of her estradiol or her E3G levels, maybe having another little peak in the luteal phase as we would expect. And then she does get a very nice, robust response PDG levels in the luteal phase. And so everything from a big blown out picture, like her ovaries are still fluctuating and having a normal pattern here. She is not, I do not suspect she is perimenopausal based off of this picture, just because this looks like what I would expect to be a reproductive picture for her hormones. I will note that she had to mark when her suspected period was because she's no longer having periods. So even though she's got a bleed reported here, she's not actually bleeding. So this was able to demonstrate, okay, patient is not perimenopausal, patient is having a normal ovarian, what we would expect response for her hormones, and also how do we play in or overlay what her symptoms are doing. Also, this was able to really kind of give us a time frame. So it looks like if she were to have been bleeding, she would probably have a probably 29 or a 30-day cycle. So that was also really helpful for us. So we were able to determine very expected ovarian hormone response in both the follicular and the luteal phase. We were able to confirm that she is still ovulating because of her progesterone response, right? And then we were also able to have her track her symptoms, and we found that during the luteal phase, she had headaches, bloating, fatigue, and irritability in the second half of the cycle when her progesterone started dropping. Um, Now, I will say that so this case report was done about 6 months prior. I actually have just recently seen the patient within the last 2 weeks, and where she noted that her progesterone started dropping, and that is when she felt her symptoms come about, which is what helped inform this decision. And I'm gonna kind of give another parallel to like how we changed course based off of what she's feeling now 6 months later. So because she was having symptoms rise when her progesterone was dropping, then we decided to add in cyclical progesterone to keep her levels elevated because she was noticing that her PMDD-like symptoms were worsening as her progesterone was dropping. So we supplemented with 200 milligrams of oral micronized progesterone at night for 2 weeks on and then 2 weeks off. And then she was able to use Mirror to discern when those 2 weeks were that she was supposed to go on. And then once she got into a pattern, it worked for her. And then I also supplemented with B6, calcium, zinc, and magnesium, as all of these vitamins and minerals have been shown to be effective for PMDD. And there's also a natural decline of B6 and calcium during the luteal phase. So just to help give her some well-rounded support. So now we can see that those progesterone levels or PDG levels have elevated. She did have an LH surge on April 19th and 20th. So that helped inform, okay, go ahead and start your PDG or your progesterone. And that's why you see this PDG elevated. And so she reported that overall she had an improvement in mood and physical symptoms during the luteal phase while she was taking the progesterone. Um, so let me pause here and just say, so this was back in April. So this was 6 months prior to when I'm recording this today, which is in December. And what I will say is that she noticed that the progesterone was actually making her over time, making her feel worse. So she stopped it. She stopped it. And what I had her do is I had her go back and start tracking Mira again so we can reestablish that pattern. Her ovarian function still looked the same as what it did when we first started working together. And what she noticed this time around, 6 months later, is that she feels worse when her progesterone or her PDG levels on Mira are highest. So we kind of flipped our plan. Now I have her on something called drospirenone, which is blocking that progesterone level at the receptor, because in true PMDD, folks on generally can't tolerate oral micronized progesterone or any progesterone or progestin, like a synthetic progesterone containing product. So now I've switched her to drospirenone to block progesterone at those receptors, and she's honestly feeling much better. So again, using Mira initially to establish this curve, introducing a treatment because at that time she reported her symptoms were worse when she was having her progesterone or her PDG levels fall, initiating progesterone based off of that information, started to feel not great again, stopped the progesterone, restarted Mira, established what her hormonal pattern looked like, tracked her cycles again, and was able to switch the plan of care. So at that time, for her summary, she's a 38-year-old patient with a hysterectomy after the birth of her second child. PMDD picture through and through, and it was diagnosed based off of mirror charting and symptom tracking. That first intervention was cyclical progesterone, B6, magnesium, calcium, and zinc. However, we changed that up a little bit, took away the progesterone and added in a drospirenone containing product to help block that progesterone, as now her levels or her symptoms were worse when her PDG levels on Mira were the highest. Um, so testing her hormones were allowed us to identify and confirm which phase of her menstrual cycle that her symptoms were happening, as well as also confirm and understand what her cycle length was, which she falls within that normal cycle length time frame. It helped us guide the timing of when we were introducing that cyclical progesterone there at the beginning of this case, and then she overall had an improvement in her mood and physical symptoms. So again, our outcome, able to identify the phase of her menstrual cycle, and her symptoms have greatly improved. I will say that we could have probably done this without Mira. It would just probably would have taken a lot of trial and error. And again, this was able to give us a very quick understanding overview of what was going on. And then again, 6 months later, when symptoms kind of changed, her clinical picture kind of changed, we're able to go back to Mira, look at that data again, and then employ a different type of treatment plan. Thank you so much.